Hello, and welcome to today's webinar, Understanding COVID-19 Vaccine Trials and Consideration for Pediatric Cancer Patients. My name is Kathy Riley. I'm Vice President of Family Support for the Pediatric Brain Tumor Foundation. We are so honored to have you joining us today for this important webinar. You will learn more about programs and resources available from the Pediatric Brain Tumor Foundation at the end of today's webinar. Before I introduce our presenters, I have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We will not get to every question today, but we'll try to get to as many questions as possible. I'd like to introduce our first presenter, Dr. Miguela Caniza, who is a pediatrician and infectious disease specialist with over 20 years experience improving the standards for the prevention and care of infections in immunocompromised children at St. Jude and globally. A native of Paraguay, Dr. Caniza received her medical degree at the School of Medicine of National University in Asuncion, Paraguay. She completed her residency at the State University of New York in Stony Brook and her fellowship in pediatric infectious diseases at Duke University Medical Center. She is board certified in pediatrics and pediatric infectious diseases by the American Board of Pediatrics. As a clinician, she cares for children with catastrophic diseases and infectious complications at St. Jude and trains the next generation of healthcare providers for these at-risk children. Her passion is to improve the standards of prevention and care of infections in children globally by building the clinical workforce and institutional processes for best care. It gives me great pleasure to welcome Dr. Caniza. Dr. Caniza, feel free to unmute and share a little bit about what's happening with vaccines.
Okay, so thank you so much for this very kind introduction. In not knowing exactly how this might work, I just went ahead and quickly, I have some few slides. Can I share those, or this is going to be more like a comment?
You are welcome to share your slides. So okay. I am going to make you a co-host, and please feel free to go ahead. You should be able to share your slides right now.
Okay, so and again, thank you so much for this. So what I went ahead and took a look at the outline that it was provided to me. So in this is the outline describing the current state of vaccine studies in children, consideration for vaccination of children in treatment and post-treatment of brain tumor, and seeing the appropriate step to take to protect brain tumor patient before they receive the COVID vaccine. And I think that these are very important questions that not only healthcare provider worry about, but also the parents. So for that, for me, it's always very good to understand what is going on with the virus. And again, I'm sure that you have seen so many times about this virus, but it still, for me, is as a point of departure, is important to understand. And so knowing that coronavirus has been there for quite some time. And so there are like 7 types of coronavirus, 4 types, they call them the human coronavirus, and the 3 types are the animal coronavirus, being the newest one, the SARS-CoV-2. So another very important fact that is very important to understand is the antigenic portion of the virus. And here it is indicating in this picture the antigenic portion, which is a spike. So the spike has a protein, and through the spike attaches to the cell the target, the receptor that has a receptor to the spike, and that is illustrated, in the figure, and you could see the model from structural biology that shows exactly where is the site for this attachment, and here shows with more closely at the place where the spike protein attaches to the receptor, which is the ACE inhibitor and receptor. Anyway, so this is how this virus go ahead, attach to the target cell, and then inject somehow the genetic information. And I think that this is a very important point that usually people want to kind of like hear, because especially now we have a number of vaccine, among them the most, I would say, the vaccine that sometimes people are, the more challenging for them to understand is this genetic vaccine. And usually I stop here and say, actually the virus inject the gene, their genetic composition continuously when they're infecting us. So therefore, this is nothing new, the injection of genetic information, because the virus inject the entire genetic information inside our cells so they can reproduce. And so that is a very important information that I usually provide to my, people with whom I talk about this. All right, the other important part also to understand is what happened during the infection. And so you could see the incubation time that goes from 0 to 14 days, and then the infection phases, phase 1, 2, 3, and 4. And this is very important dynamic to understand, because in each of these phases, there are some specific viral effect, and then you have the immune response and what happened with the various organs. And again, this is a very important concept to really review with the in view of having the vaccination, because it's going to be the choices of what the vaccine is going to be doing versus what the infection is going to be doing. And again, the two types of immunity that face challenges the virus. One is the innate immunity, and the other is the adaptive immunity. And that sometimes also bring to another question that they say, is the infection going to provide immunity? And the answer is yes, but at the expenses of producing a lot of destruction, because also some the innate immunity participate to clean up the mess done by the virus. So passing by, and this is a very important information that came early this year. In this information, the investigators share the duration of immunity. And again, I like this slide because it's very simple. This figure is very simple, very easy to understand. The immune response are integrated by the activation of the memory cells, the production of antibody, and then the activation of the T cells. And so in this figure, it shows the percent of participants that responded producing these 4 types of immune response, being in black those that have all the types, in being those in white those that did not have. And so you could see that at 1 month and at 6 months still, there is a very important percentage of infected people still responding with this immune response. Okay, going to vaccine. The vaccine certainly, the traditional pathway for the vaccine development and production and distribution, it takes from 8 to 20 years to go through the various phases, the preclinical and the clinical, and then the distribution. And certainly the COVID vaccine came out very quickly, like between quotation marks, And that is usually another argument that people put forward, and I understand perfectly when they are saying to me, why this vaccine has been developed so quickly versus other vaccine that took forever. But again, remembering that the one that we have is SARS-CoV-2, but then the SARS-CoV-1 appeared 20 years ago, and since then, the investigator has been working already to better understand this virus and to develop a new, more like innovative vaccines. So for me, it's helpful to reflect on that and provide that type of explanation. Okay, so in the other explanation is like in the face of the pandemic, there are strategies being used to accelerate the production of vaccine. And these are the strategies that some phases of clinical trial are combined, and because the cases accumulate very quickly, so therefore the answer to the question come out much faster. And then because of the incredible interest in developing vaccine, manufacturing capacity also expand during clinical trial. And so all those things help to come out with the vaccine. And so there are a lot of vaccine being produced, and this is a site that is, I really like the site because it's very friendly, it's very easy to understand and good information. And it tells us that there is so many vaccine in phase 1, phase 2, phase 3, authorized, approved, and then also there are some other some other vaccine that has been abandoned. And so I work at global sites, and so people, like, of course, all over the world are very worried about receiving, the vaccine and getting vaccinated. And I always assure them that is so much vaccine being produced that is going to arrive, but they just cannot see that, meaning they want this to come as soon as possible. So these are the living vaccine, and you could see on top, you have the Pfizer, the Moderna. So those are the genetic vaccine because it has the messenger RNA, but then you have the other type of vaccine that uses the viral vector, and then other that are protein vaccine, are inactivated vaccine. So the Pfizer vaccine is very straightforward. As I already show you, the vaccine has a spike. And so for the spike, basically, there is a genetic information inside the virus, and that is placed into a lipid nanoparticle. And that is the one that the recipient of the vaccine are injected with, and that produces the spike present to the antigen presenting cell, stimulate the immune system to produce the antibody. So next time when this virus enter, actually the neutralizing antibody face and hopefully eliminate the virus. So this is the way that this works. And this was a very important publication that came in the New England Journal of Medicine that I'm sure that everybody were cheering after they saw this information early this year, sorry. And that shows the efficacy of 95%, after 2 doses of the vaccine. So, and that was like big relief, and a lot of, I'm sure that so many places were cheering when they saw that, because it was a huge hope for the coming out of this horrible pandemic. And these are the places, and I took that like a few weeks ago, places where these vaccines are being distributed, and you can see that you have Pfizer and you have Moderna. But again, this changes so quickly. So please take a newer information, because this is already by the standard. So people usually talk like by the COVID time, this is already old. And of course, these are more of the genetic vaccine. And then of course we have the other type of vaccine, which is the viral vector vaccine. And you see there the 4 types: the Gamaleya, the Oxford AstraZeneca, the CanSino, and the Johnson & Johnson of the J&J. So these uses a viral vector to transport the genetic information of the spike protein. And again, very quick showing, how this might work. And these are specific viruses like designed to transport the gene of the coronavirus. And pertaining to children with cancer, this information is very important to understand that these are non-replicative adenovirus, because usually in the oncology world, we usually very quickly see, is this live virus or dead virus? But again, very important to remember these are non-replicated virus. So therefore, it's not going to be like very dangerous for children who are immune compromised. And again, the mechanism is basically the same. Instead of using a nanoparticle that is going to surround this genetic information, uses a kind of like a shell of a virus that where the genetic information is placed. And so the virus injects the information, and the host cell produces the protein, and the antigen presenting cell presents to the adaptive immunity component to produce the neutralizing antibody. And this is a very important publication that came published in Lancet. And this was the Russian, we call it the Russian vaccine, but this uses the viral vector, and it shows that the efficacy is really fantastic. And so over 90%. And so what about in pediatrics? We know that these vaccines, at the beginning, it was approved for the age 18 years and older, but then the younger one was approved just recently, between 12 and 15 years of age. And that was very, very, we were like all very happy about that, because then children also, those age 12 years and older was going to be able to receive, especially the Pfizer vaccine. And that was, that recommendation was based on the result of the study, that it was that it showed the response, very good response of studying over 2,200 children, 12 to 15 years of age, that showing that half of them received the vaccine and half received placebo, and showing that there was 18 cases of COVID in those groups that received placebo. And that number was enough to say that this vaccine, the efficacy-wise, is appropriate to recommend. And again, these vaccines they have the emergency use authorization, which is the recommendation is for during the pandemic. Still does not meet the criteria to incorporate into the regular recommendation, because this is applicable during the pandemic. I'm sure that more paperwork and more application needs to be done so that they can introduce into the regular vaccine recommendation. All right, so I think that one of the question and one of the worry that I think a few, probably like a few weeks ago, was the information of myocarditis in children among those who received this vaccine. And that was like a big buzz. And so that we had a conversation with our cardiologists, and this is the publication that came. And this is like a serious symptomatic acute myocarditis in 7 adolescents following the Pfizer BioNTech COVID-19 vaccination. And it shows that this event. But I highlighted here that they say that there was no causal relationship between vaccine and myocarditis that has been established. And that was very important to understand, because people are still talking about this as they kind of like saying maybe that should be the reason why we should not vaccinate. But again, to argue for the vaccination, despite that, are other publications that came showing that COVID actually produces myocarditis. The virus itself produces that, and probably the percent is much higher. and it could be also even much more severe. And so those are conversations still going on, an important argument that it is helpful to have the information and the facts. Okay, so now vaccination in pediatric cancer occurs, and there's a lot of other established vaccines that we normally give to children with cancer. This is just a compilation of all the vaccines we have and all type of vaccine you could see here. And so that is a very important information to pass along to our colleagues in taking care of children with cancer, including children with a brain tumor. And so what about for COVID-19 vaccination in pediatric oncology? So these are like very quick facts, like authorized COVID vaccine are all inactivated vaccine. The advisory committee for immunization practices state no preference for any of the authorized vaccine. Authorization, again, was based on phase 3 trial conducted at various time and location, and vaccines were tested against different circulating variants. And this is something that people need to remember, that very quickly we have new variants coming up, and the setting were the settings were different background incidents. All authorized vaccine demonstrated efficacy, the range 65 to 95% against symptomatic lab confirmed COVID-19, and all authorized vaccine demonstrated high efficacy. So again, at St. Jude, all age are eligible, meaning all age eligible St. Jude patients would be benefited from vaccination unless contraindicated. For hematopoietic stem cell or transplant recipient, they may develop their immune response if vaccinated after 100 days post-allo transplantation or over 30 days post-autologous transplantation. And so, and these are the vaccines that this is how we offer for those ages 18 years and older. So we give Moderna, Janssen, or Pfizer. For ages 12 to 17 years, we offer Pfizer. And these are the dosages that we use. And then you could see here the Janssen, it is only one vaccine. But the Moderna and the Pfizer are two shots. And like Moderna is given day 1 and day 28, and the Pfizer day 1 and day 21. And this is the summary of the COVID vaccine authorized by the FDA under the emergency use authorization. Remember that that is applicable, meaning the authorization is during the pandemic. And so again, we talk about the contraindications also, because it is very important to know when not to give. And so we follow what the CDC recommends, that the contraindication basically are allergic, severe allergic reaction like anaphylaxis after previous dose or to a component of the COVID-19 vaccine. So, and that is something that it will be very important just to have there. What are the components of the COVID vaccine, COVID-19 vaccine? Not precisely the genetic information, but the content. You know, some of them are specific additional component that is important to know in case that the patient might be allergic to those components. So it could be that they might be allergic to a component that Pfizer has, but not Moderna or Janssen. So that is important to know. So immediate allergic reaction of any severity to a previous dose of vaccine is a contraindication, a known allergy to a component of the vaccine.
Dr. Caniza, this is a wonderful information. We're running short on time, so I don't know if you have just one more slide or two, but we'll need to move on to our next. We'll need to move on shortly to our next presenter.
Okay, so and I think that those are the most important information that we have, and so and I would say probably that is I was arriving to the conclusion that the leading COVID-19 vaccination are effective and safe. There is a huge diversity of vaccine that is important to know and vaccinate. really vaccinate. And so I think that that is what I wanted to share, and sorry for going over time.
Thank you so much for the depth and the breadth of that information. We appreciate so greatly everything that you shared with us, and thank you, and look forward to you participating in our Q&A. If you'll stop screen sharing now, I'll introduce our next speaker. Dr. David Kimberlin holds the Sergio Stagno Endowed Chair in Pediatric Infectious Diseases at the University of Alabama at Birmingham, where he is Vice Chair for Clinical and Translational Research and Co-Director of the Division of Pediatric Infectious Diseases. Dr. Kimberlin is also editor of the 2021 American Academy of Pediatrics report of the Committee on Infectious Diseases, known as the Red Book. Since 2007, Dr. Kimberlin has served as the American Academy of Pediatrics Red Book liaison to the CDC Advisory Committee on Immunization Practices. Through his work on these committees, Dr. Kimberlin has been involved throughout 2020 in major decisions nationally on allocation of the COVID vaccines as they become available. This includes the assessment of the safety and efficacy of the vaccines in populations studied to date, and the development of the phased rollout of the vaccine to the American public to reduce transmission, morbidity, and mortality of COVID-19 disease. Dr. Kimberlin, it is wonderful to have you with us, and I'll hand things off to you now.
Well, thank you very much, and I greatly appreciate the opportunity to be with you all this morning, this afternoon, depending on your time zone. And it's a privilege to follow Miguela and be able to hopefully complement the tremendous information that she provided. There will be a little bit of overlap, and I'll try to move through those areas pretty quickly. If I could advance to the next slide, please. In terms of disclosures, virtually all of the research that I conduct is funded by the National Institutes of Health, NIAID in particular. I do occasionally do industry-sponsored studies. The only one I've been involved with recently, and the only one of relevance here, would be a Gilead study of remdesivir, which is an antiviral used for COVID. I've not done any and don't plan on doing any studies with respect to vaccines, which would be the topic that we're going to be talking about today. But I did want you all to be aware of this. All monies from any of these activities, of course, go directly to my university. They don't go to me at all. Next slide. This is a schematic of the different kinds of vaccine platforms that are out there. Miguela did a fantastic job, I think, with better graphics of what those are. The ones we're going to be talking about are in the center part of your slide, in the blue kind of oval shape, the mRNA vaccines, and then in the lower left-hand side, in the purple oval, the viral vector vaccines. Next slide. And this slide demonstrates or tries to summarize the status of 5 of the most prominent of these vaccines that are coming along. And if you kind of look across the rows, the platform, that is the type of vaccine that it is, what the authorized dose and schedule is, and what the current status is in terms of emergency use authorizations for all these, because none of them have FDA approval yet. I think Pfizer's is before the FDA for approval for adults, but none have had enough time yet to receive approval. And then the status of evaluation or authorization in adolescents and younger children. So looking at the column second from the left for the Pfizer BioNTech vaccine, it's an mRNA vaccine. We've heard how it encodes the spike protein. It's interestingly, it's a stabilized spike protein. So in other words, the genetic information that encodes this protein with the final product is what's called a stabilized product, as compared to a wild type product that we'll talk about when we get to AstraZeneca. And that is part of what makes this vaccine so remarkably effective. It's given over 21 days, 2 different doses. Current status is emergency use authorization for 12 and older. The adolescent EUA was approved May 10th of this year. And the dose-ranging age de-escalation studies in younger children are underway. Word on the street is that we may have information from those in the fall, September, maybe early October. And as soon as they are available, assuming that they show a good response as well as a good safety profile, I would anticipate we'd have authorization for under 12 years of age as we're into the next school year, you know, September, October-ish range. Now, the next column over is Moderna. It also is an mRNA vaccine. It also encodes for a stabilized spike protein, 2 doses, but are given 28 days apart instead of the 21 days apart with Pfizer. It currently has emergency use authorization in 18 years of age and older. An EUA has been filed for use in adolescents 12 through 17 years of age. That filing was just a few weeks ago on June 10. And as I understand it, it's under review right now at the Food and Drug Administration. Moderna is also doing age de-escalation dose-ranging studies, and those results also are expected in the fall. The J&J vaccine is the replication incompetent vaccine. As Miguela said, it is not a live vaccine, and it is utilizing a human adenovirus, a harmless human adenovirus that carries the mRNA for a stabilized spike protein for coronavirus in it as well, SARS-CoV-2 in it as well. It's a single dose, although they are testing in additional clinical trials a 2-dose schedule given at day 1 and day 56. It currently has EUA authorization for 18 years of age and older, and they have expanded an earlier study to include teens. This is an international study, also has US sites, and they have plans to do a younger child dose-ranging age de-escalation study. AstraZeneca uses a replication incompetent chimpanzee adenovirus, unlike J&J, which is a human adenovirus. Now, AstraZeneca uses the wild type spike protein, and that may be why it has less activity, apparently, at least from studies out of South Africa, against some of the variants. It's a 2-dose vaccine given 28 days apart. The EUA is termed complex by the US Food and Drug Administration, and as I understand it, the company is addressing some of those complexities in what they ultimately, as I hear it, plan to submit to the FDA. They are enrolling adolescents in the UK and younger children in the UK as well. And then finally, on the far right column, I'm leaning in to move my little pictures of all of us. The Novavax vaccine is a baculovirus expressed stabilized spike protein, 21-day intervals between the 2 doses. Phase 3 studies have been complete. As much as is happening around and throughout this pandemic, this is science by press release. I've not seen, to my knowledge, no one except maybe FDA has seen the actual data yet, but what's reported looks really good, which is what I want to believe. They do have an expanded phase 3 study in 12 through 17-year-olds that's enrolling, and they're planning a dose-ranging age de-escalation study in younger children. Next slide. This is a summary slide of sort of the safety and efficacy of these 3 vaccines in adults. Now adult for Pfizer on this slide is a bit loosely defined because it actually includes 16 and 17-year-olds. But this is where you see that pain at the injection site is frequent, 60 to 90%, depending on the studies. Fatigue, maybe in 35 to 50% or so. Some headache in about the same percentages. Muscle aches, myalgias, joint pains, are in the 20 to 30% range, generally speaking. Fever is anywhere from single digits up to 15% or so. And then we look at the efficacy. This is how good they are, and you can see that they are, just simply outstanding. Somewhere in the 90 to 95% range in preventing severe disease and all disease for the mRNA vaccines as well. Next slide. I'd like for us now to talk more about adolescents, because that's really, I think, the population that we're going to be discussing the most today. So if I could go to the next slide, you're going to see the layout on this slide of the different columns. We have the group of 12 through 15-year-olds, about 11,030 of them, who received active vaccine, and then fourth column, I guess, from the left, the placebo as well. And then they have a comparator group of 16 through 25-year-olds that have about 1,900 subjects in those. These are data from the ACIP meeting at CDC in mid-May, and that led to a recommendation for use in 12 and over for the Pfizer vaccine. And the New England Journal publication has come out and has much of these same data as well. I think these data might be a little bit more thorough from the ACIP meeting, which is why I pulled them from here. You can see that in terms of racial balance and ethnicity balance and country, what the representations are. I think the only thing that catches my eye is about 3/4 of the way down in terms of Hispanic and Latino. For the 12 through 15-year study, it was predominantly in the US, and the percentage that was Hispanic was in the 12% range or so, unlike the 16 through 25-year-old comparators, where it was about 1/3 of enrollees that were Hispanic or Latino. Other than that, I think these numbers look quite balanced across. Next slide. What we see here is local events that are occurring, so basically at the injection site. And this is following dose 1 in the upper panel and dose 2 in the lower panel. And then each of these break thresholds, redness, swelling, pain at the injection site, are also broken down by age, 12 through 15, 16 through 25, and whether they got the vaccine. That would be what the 30 microgram column is, or a placebo, which is marked as placebo. So basically you can see that there's been some redness and swelling, maybe 6% or so overall, 7 to 8% of those with first dose or second dose. But it's really the pain at the injection site that's the issue. And it's the same as with the adults. These percentages look very, very comparable. Somewhere in the 75 to 85% range will have pain at the injection site. It feels like a Tdap kind of discomfort, or if you're older like me, the Shingrix vaccine. It's some achiness at the injection site, but it goes away after a day or two. Next slide. Looking at the systemic events, and this is following dose 1. We have fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, and joint pain. And then we have the B&T upper figure, that's the active vaccine, and the lower figure is placebo. And you can see that you're more likely to have some fatigue and headache. Although interestingly, the placebo also generated, as a placebo effect can do, some of those complaints as well. Muscle pain, again, very similar percentages to what we're seeing with the adults. This is following dose 1, and on the following slide, we're going to see the results from dose 2, and a little bit more prominent results or complaints following dose 2, again, similar to what was seen with the adult study. Next slide. Now, the main point of doing the pediatric or the adolescent study, I should say, the 12 through 15 study, was to get the safety data that we just went through rather quickly, but then also to measure the antibody response, the immune response to the vaccine. And so what you see on this slide is what's called the geometric mean titer, which is a way to measure how much antibody is generated following a vaccine, in this case, the COVID Pfizer vaccine. Day 1 is the day of the shot, the first dose, and day 52 is day 52 afterwards. So that would be after the 2 doses had been administered at day 1 and day 21. In the more purple bars, if that's a word, is the group getting the active vaccine. The bluer bars are the placebo vaccines. And you can see what the overall immune response for the 12 through 15 years was. Note the 1283 number over the second column from the left, and the 16 through 25 on the right-hand portion of the slide. Note the 731 or 30.8 number over the column second from the left in that particular portion of the slide. And really, if you look at the overall height of these bars, they look very similar. But if you look to the far left, you see that it's a logarithmic scale, and that's why there's not a greater separation between these. Now, on the next slide, we're going to look at the geometric mean ratios, and that's where this roughly geometric mean titer for the 12 through 15-year-olds of about 1240 versus the 705 geometric mean titer for the 16 through 25-year-olds. And then if you simply divide the larger number by the smaller number, you end up with a ratio of 1.76 with a range of about 1.5 to a little over 2. It basically means that these younger adolescents have an even more robust immune response, which is good, to the vaccine compared with the 16-year-olds through 25-year-olds, roughly 1 3/4 increased fold response in the geometric mean ratio. Next slide. Now, Miguela talks, forgive me, I'm going to get ahead of myself. Let's look at some of the numbers. Miguela had shown a press release from Pfizer that preceded the submission of these younger adolescent data to the FDA. And what's illustrated on this slide is the vaccine efficacy. How good was it at preventing the disease? You can see that in the placebo group, 16 subjects developed COVID following 7 days or more after their second dose versus 0 in the B and T group, that's the active vaccine group. And so that's a vaccine effectiveness of 100%. And that is in patients without prior infection. Next slide. In patients with or without prior infection, it's 18 and 0, again, vaccine effectiveness of 100%. Wonderful news. Now, these numbers are pretty small. The more important information is the antibody response that we went through, but I'd rather see these numbers than not see these numbers. Next slide. Now, Miguela talked some about the myocarditis pericarditis issue that's getting so much attention these days. The ACIP meeting last week did present some data, and I just pulled maybe, I think, 3 slides that I think will be important here. There actually is now a linkage, and it's a very rare kind of a consequence of vaccination, predominantly dose 2 of the vaccine, more likely in males than females. But it is there, and this has now been shown in the vaccine safety data link system, and that's what these numbers are representing here. So what is in the boxes are the numbers per million doses, and this is within 21 days after either dose 1 or dose 2. Dose 2 is the one probably we should pay more attention to, and you can see that for females, 4.7 cases of myocarditis pericarditis have been reported per million doses of dose 2, and the number for males is 32 per million doses. So I did a little stuff below this that I hope anyway puts this in some perspective. 32 per million is 1 per 31,250. So you just simply take 1 million and divide by 32, and that's where this 31,250 comes from. That's 31,250 second doses. The chance of being struck by lightning across a lifetime is 1 in 15,300 people. So basically, and this is a kind of a cute comparison. It's not a scientific comparison. But I do want you to know we need to keep risk in balance in your mind. And for me, having a twice as likelihood of getting struck by lightning over the course of my lifetime versus having my young adult son get the Pfizer vaccine, for instance, and having a 32 in a million chance, to me, that's well worth the vaccine. And if you look on the next slide, this is shown graphically on what the cases of myocarditis per million doses are on the right-hand portion of the slide, and the hospitalizations prevented by age on the left-hand portion of this slide, a graphic that I'd like for you to have in your mind. And then my final slide is next, And this is looking at it not only for hospitalizations, but it's by age and gender on the left-hand column, females 12 through 17, males 12 through 17, females 18 through 24, you can work your way down. The numbers of cases of COVID prevented per million second doses, the numbers of hospitalizations prevented, the number of ICU admissions prevented, the numbers of deaths prevented, and the estimated numbers of myocarditis cases following dose 2. So again, gives you a chance to look at this. I'm going to finish with my final slide, which is a picture of our Children's Hospital. We like the way that looks, so I always like to include with that. Kathy, I'm turning it back over to you, and I appreciate very much your time and your attention.
Thank you, Dr. Kimberlin, for that incredible scope in helping us learn more about the vaccines and safety. It gives me great pleasure to introduce our next presenter, who will speak from the neuro-oncology perspective. Dr. Eugene Wong is part of the Children's Hospital Pediatric Neuro-Oncology team focusing on treating children with brain tumors. Dr. Wong has developed and led many novel early phase therapeutic clinical trials with a focus on immunotherapeutics. He also leads trials focused on gene therapy and new targeted agents. He is the site principal investigator of the Pediatric Brain Tumor Consortium, where he is co-chair of the Immunotherapy Working Group. Dr. Wong is not only dedicated to finding a cure for cancer, but also to making the current treatments as safe as possible for children, and is involved in several international efforts to study how to best mitigate treatment side effects. Welcome, Dr. Wong.
Great, thanks, Kathy. Thank you so much for your invitation to participate in this really important topic and kind of a timely topic still, even though we've been living with it for the last year and a half. I really have to say those are two really great summaries about COVID and vaccines for both adults and pediatrics. I myself learned quite a bit there, but don't expect to get a lot more COVID information from me. I really wanted to talk more about the perspectives of how COVID has impacted many of the people who are on this call, the children, their families, their communities, as they've gone through battling a cancer or a brain cancer diagnosis. I think still it's really, this whole topic, I think, still remains so important to our community because, there are still variables that are occurring. New variants of COVID become more common. Places in the US are starting to reduce or eliminate restrictions. And it's well worth it to remember how hard this pandemic has been and continues to be, not only physically on all the patients and their family members who have contracted COVID, but on all the rest of us. And you layer that on top of trying to battle something which is literally the worst possible battle that you could potentially face in your child in the context of a cancer diagnosis. That's, something that really starts to add up and something that I think that we're all trying to struggle through together and get out to the end of this. When we talk about the impact that COVID has had on our children with brain cancer or cancer, it really starts to fall into a few separate categories. One of those is, of course, on how the treatment and the diagnosis of that child has been affected. Now, unfortunately or fortunately, children with cancer or cancer itself, that sort of trumps a lot of the concerns about staying separate. If you have something that needs to be taken care of as a hospital, as providers, as a community, we still rally around those patients and have been doing that quite well. But there are a lot of changes that have been really hard. I've heard some terrible stories about how in the adult community, there are patients who have COVID or other life-threatening illnesses and they have nobody around them. They're not allowed to have anybody around them because we've had to be very safe about COVID. Unfortunately, while we can mitigate that somewhat in pediatrics, that's still true. We have children and we are allowed, for a long time, we allowed one person and it had to be the same person. And so that adult perhaps had other kids or other family members or other responsibilities. And previously we'd been able to have support from the entire family and their friends and their communities. Now it's one person, they're 24/7. And so that becomes really a struggle for a lot of these patients and for those in their own groups and their support networks who really, really are desperate to see them and be with the child who's facing a brain tumor, for instance. It's definitely, I think, diverted, and unfortunately so, resources away from some of our treatments and our diagnostics because, quite honestly, there was an even bigger problem for the community, i.e. facing COVID and trying to redistribute or even create mechanisms for treatment for those patients as well. And then it's not just within the hospital that those children have been affected, it's within their own communities. You know, friends, school is all remote. Friends don't get to come over as much. Families don't get together. The children can't travel on Make-A-Wish trips when they're able to. And sometimes the times when a child is able to go enjoy life with their family and their loved ones, and in our diagnostic world, sometimes those are rare. And you want to be able to take advantage of them. And you couldn't. You couldn't because COVID had really shut down everything. And then there's a whole nother section which in a way impacts these children's and families even more dramatically, although it's not right in their faces. And that's in designing and finding the next treatments for those children. It's no secret. In pediatric brain cancer, we have great treatments for some kinds of cancers, and we have pretty crappy ones for many others. And the scientific and clinical trial communities have done so much in the recent decade to learn more about these tumors and to devise more treatments. And all of that really came to a screeching halt when COVID came in, not only because of the resource allocation we were talking about, but because we'd have to take care of patients who really need it, but maybe we didn't have to have researchers in the lab, potentially transmitting COVID to themselves or amongst themselves or to their clinical colleagues or to their patients. And so not only were the labs shut down, the funding sources, from groups like PBTF started to drop a little bit as fundraising events could no longer happen. And so suddenly this COVID affects literally every aspect of a child with brain cancer. It affects what happens when they're diagnosed and treated, who can support them. It affects what happens at home to keep them as happy and as strong as they can to get through these trials and these travails. And it affected our ability to devise the next treatments for them. Now, much of that is starting to come back online, which is really on the backbone of this tremendous and really inspiring devotion of many, many nurses and doctors and community members who have really come together to really tamp the COVID pandemic down a little bit at this point. And so we're excited and looking forward to some of these things really coming back online. And they have been. From a purely safety perspective, and I know that that's a big question. So when you have a child with brain cancer undergoing immunosuppressive therapy, whether it's chemotherapy or immunotherapy or targeted therapy, what does COVID do to a patient? As families, I think that we see on the news and from experts like those that we've heard today, that it's really important for our children to be vaccinated. But there's always that other subtle counter narrative that children who are in general healthier than adults in many ways can withstand some of the side effects of COVID. And so the vast number of hospitalizations that we were seeing during the height of the pandemic were really adult oriented and not pediatric oriented. And so since many of the questions that sort of pre-populated this webinar about how is the safety of the vaccines, and I think we've heard some really amazing information about how safe they are. Those are natural questions to have because parents who love their kids and want to make sure that they aren't exposed unnecessarily to things that could hurt them are doubly concerned when that becomes a situation when you're dealing with cancer and chemotherapy. So our hospital, along with many other very large pediatric oncology centers across the country, have been collaborating. They've been trying to get that data. So how sick does COVID make a child who's got a diagnosis of cancer and or who is going through treatment for that cancer? And that number is not insignificant. So that number is higher. So basically, when one of our children and our patients in our community contracts COVID, a greater percentage of them get sicker, and a greater percentage of them have COVID than perhaps the other general population with the general sort of pediatric population who isn't going through these things. So we as a community are very focused on protecting our patients, the children with cancer and brain in general, brain cancer in specific. That means that right now, every kid who is eligible to receive a vaccine, we are strongly recommending as St. Jude's does that they do so. Much like we strongly recommend that those children get flu shots and flu vaccines as well, because we know and we're worried about what the impact of a COVID infection will be on somebody whose immune system isn't really up to snuff at that time. And whilst you heard that there is in the community, I think, some focus on the very rare side effects that can occur in some situations, I think that Dr. Kimberlin gave such a great like those examples and those numbers are really compelling. I mean, we really at least believe that that preventing a COVID infection in one of our patients is so much more important than a very, very tiny fraction of potential side effects that you can get. Now, that's not to say, and this is something that should be expected, there's It's known that children's immune systems can be very responsive, and sometimes that means that they can be quite reactive. And so some of the more common side effects that you can get from the infection, not the infection, from the vaccination do occur, and they may occur more commonly. I'd be interested to hear the perspective of the infectious disease specialists on this call in our children who are getting the shot. However, at the same point, I think that we're very encouraged by what seems to be, at least in preliminary data, the very nice response and protection that the vaccines provide to children who are getting the vaccines. Now, one of the thoughts that I've fielded from my own parents of patients that we treat currently is, okay, so you just told us that our child is immunocompromised. We understand that. We know it's a necessary evil to get through the treatment for this cancer. But does that mean that this shot or this vaccine is or isn't going to work? And again, I'd love to hear that question answered by our experts that are on this panel already. In general, we still recommend that they get the vaccinations. We believe, at least in our hospital, that there will be at least some protection conferred by the vaccine, and really any protection against this really devastating virus is super important. And then, it's interesting, there's another perspective that I just heard a few weeks ago, which was as our communities starting to lighten their restrictions and people feel freer and aren't wearing masks quite as often or aren't washing their hands and they're congregating more, there's been some concern from parents, interestingly, that COVID in a strange way was actually protective for their kids, because during COVID, people weren't running around infecting each other with the common cold or the flus or those sorts of things. They were wearing masks, including their own child. And so not only from a psychological perspective, that their children who were sometimes wearing masks or being very careful about hand washing were now normalized to a large extent because everybody was doing that. And now that is starting to shift, at least in the United States for the present time, that not only is that more of a psychological issue for some patients, but also we are starting to see a pretty hefty increase in non-COVID viral infections in at least our communities around the hospital that I work at. What that means is it's no shocker to think that once you start to individually release some of these restrictions, that the normal viruses that have always plagued our society, that they are going to rear up. And so interestingly, again, I think that there's yet again another fear, which was one fear, which is getting COVID and preventing COVID. But now, interestingly, the other fear of now that COVID is maybe getting a little bit better, now being exposed as a family and as a child who's going through this treatment to other viruses that have had a little bit lessened risk during the time of the prime time for COVID. I think really just to summarize, and I just wanted to keep this short. I know we're at the 2 o'clock, and I'm really interested to get to some of the questions that have been asked. Our families and providers, the people in our community of children with cancer and with brain cancer, it's been an incredible challenge, because not only are you faced with probably the worst possible obstacle that you can face, but now you've layered on an entire nation of concern with pandemics and with COVID. And it's been hard, but it's still going, and it's still ongoing. But it's been truly inspiring to continue to work with people who have worked literally around the clock trying to figure out how to make this better, and to work with parents and families who have also, really jumped in with both feet about how to protect their child and how to get their own personal communities to engage in that effort as well. I do believe that our patients with brain cancers can be kept safe with vaccines and other restrictions. I think that in the context of those elements, that it's still going to be important to maintain quality of life and to do the things that you can do at the times that you can do them. So, again, I'm very, very, very grateful to be invited to talk about something that's been unfortunately really prevalent in all of our minds during this past year and a half, and look forward to the question and answer session as well. Thanks, Kathy.
Thank you, Dr. Wong, for that presentation and for your thoughtful and meaningful words for the pediatric brain tumor population. I want to invite all of our presenters now to turn your cameras on, to unmute, and we welcome questions from all of you who are attending today. Please type any questions that you have into the Q&A feature at the bottom of the window. We've already received some. I'll begin with those. Unfortunately, we won't get to every question today, but we'll have a survey at the end that you'll be able to fill out. And any remaining questions you have, we invite you to put those questions in that survey. I think this question that I'd like to start with has already been answered, but to put a finer point on it, I think this is one of the primary questions that I want to make sure there's a solid answer for this. Someone in the Q&A says, should I give a 13-year-old boy who's on chemo the vaccine? And that is a question that came in multiple times at registration. Should a child actively on treatment be vaccinated? Dr. Wong, I'll start with you, but this is a conversation, a discussion. So Drs. Kimberlin and Caniza, please jump in as well. But Dr. Wong, could you answer that question for us?
Yeah, I think through all three presentations, we heard a bit of uniformity there, which is that, again, like the flu shot, which we recommend 100% of our patients on active therapy get, the risk to those patients, to our patients for getting the flu vax, or in this case, the COVID vaccine, in our eyes has not been that there would be some untoward event, a side effect or something that would be harmful, more so than in the general population. It's really, and I'd love to hear more detail about this from the other panelists, but I think that maybe one concern is if you don't have a great immune system at the moment because of treatment, will you respond and will you gain that immunity? And interestingly, I've had some personal experience with this in my personal family who has chemotherapy ongoing. And one of the tests that has been done is to check the body for antibodies to COVID in the context of a vaccine. And in those situations, at least I've noted that even though in these personal experiences that, that the immune system has been pretty weak, that there is a great response antibody wise, at least in that particular perspective. So for many reasons, it's not that you wouldn't get some of the fevers and the aches for that first 24-hour period potentially, but it's that we don't think those are dangerous to you as a patient. We think that that you will get some immunity, if not all of it, from the vaccine, and that those are incredibly important. But I'd love to hear again from the infectious disease specialists.
Yeah, and again, this is a very common question, and since I work around the globe, that is the first question: should I give to my patient who is receiving induction or other? So. And again, I bring that question to St. Jude because I see patients there too. And it's interesting because the recommendation is if you get the chance to give it, give it. So there is no specific hide up with the chemotherapy regimen, but with the transplantation. So that is why it's kind of like specific, how many days post-transplantation you can give. But regarding chemotherapy per se, there is no really any specific rule about that. So if you can give it, give it. Certainly, most of these vaccine, and knowing that in the panel are people who are concentrating on that. My specialty is pediatric oncology and infectious disease complication and prevention. So normally, what I see, and my colleagues also, is like most of these vaccines in pediatric oncology are based more on safety instead of the efficacy per se. So kind of like it is not going to hurt, it's going to help, but not, it differ. And I think that is one of the questions also, what about the efficacy in those with those vaccines? So I think it's going to be very diverse. And again, I want to hear what David might say about that.
I agree completely. I mean, get the vaccine, and I would expand on that. Get everybody around your adolescent to get the vaccine too. It's that bubble effect, and honestly, we're at a point in this pandemic, in my judgment anyway, that the three talking heads you have here on your screen, we can do our part, and we will continue to try to do so, but we're not going to be the influencers, the trusted messengers, which is the phrase that now we're focusing on so much. It's y'all. It's folks that where you can go to people and say, the grocery store, please. I'm not saying you don't want to become like you want to do it with the politeness and everything, but encourage people to get vaccinated, and the folks that are reluctant to do so, if you tell your story of how they would be helping protect your son or your daughter, maybe that'll be enough. Maybe it won't, who knows, but it's the best shot we have to get. Now that we've gotten the people that want to get vaccinated, we got the next step, which is going to be a bigger step to try to overcome.
So another question that's come in the chat, and I think we've addressed this, but I want to make sure that we're clear to the questioner is, so is the immune response different in kids undergoing treatment or have compromised immune systems? And Dr. Kimberlin, do you want to start with that?
Yeah, I mean, the full answer is we don't know. It almost certainly is. I mean, Miguela would know much better than I would, but I would be surprised if the response is not less than what it would be in an immunocompetent younger adolescent. Now, that said, the response is so phenomenal that it may still well be good enough, but those studies have not been done yet.
And then Dr. Caniza, did you want to add to that? And then there's a question directly for you in the chat that I'll go to next.
So what I was going to add is that the chemotherapy in these patients are so diverse. And so, and then the phases also, it could be that this month, maybe the immune system is working much better, but in 2 months from now. And so that is another factor also that to take into consideration.
And then the questioner in the chat was asking, what was the time frame of giving the vaccine for transplant patients? Dr. Caniza, I believe you touched on that in your earlier comments.
And that is one of those, they say in allogeneic transplantation, give 100-day post-transplantation. And for autologous, 30 days post-transplantation. Those are the numbers.
And then an additional question that we received at registration, does it matter which vaccine that pediatric cancer patients receive? Dr. Kimberlin, could you field that question?
Yes, because the only option you got is Pfizer. Moderna is 18 and over right now. J&J is 18 and over. So right now, the only authorized vaccine for 12 through 17-year-olds is the Pfizer vaccine. So once Moderna is authorized, and I fully expect it will, we need to look at the data. Of course, the data will be in immunocompetent adolescents, not in immunocompromised. But we got to see the data first. I would expect at the end of that assessment, it would be either Pfizer or Moderna, but we're just not quite there yet.
Great. Dr. Wong, we've had some questions at registration surrounding what are the specific risks to post-treatment patients for COVID? Are they at increased risk? Could you talk a little bit about patients who are post-treatment and recommendations for vaccines?
Yeah, absolutely. So I think that there are a couple of avenues to explore here. And I'm going to talk specifically within the context of brain tumor survivors, although it would probably hold true for pediatric cancer survivors in general. We know that depending on the deficits that you face during your brain tumor, from the treatment, that there are some, I think, some difficulties that our patients can sometimes face that are a little bit different from some of the other things that other pediatric cancer survivors can face, namely neurologic impact of their treatment and their tumor. What that means is that if you have a difficulty with swallowing or with sometimes if you aspirate or get food or liquid into your lungs instead, or if there are other elements where you were not as able to be quite as physically active or had other organs compromised because of your brain tumor, then I think in those situations, it's not so much that COVID is more impactful to you from a biological or an immunological sense. Your immune system is not different. It's more that the rest of your body has a little bit less reserve in that situation than perhaps another child might. And in that situation, I would anticipate that maybe we don't have those numbers to really hardline how much more risk you're at, but we do know that people who have underlying conditions that can affect them are at greater risk from complications for COVID. And so in those situations, I think that would also be true. In general, though, from an immunological standpoint, when our patients are done with their chemotherapy and some months after that, we view them as immunocompetent, meaning that we view them as having normal immune systems. And in those situations, if you're a survivor and you're years out from your treatment, I wouldn't necessarily view as any higher or lesser risk than the next child who's your age. from COVID.
Great, thank you for that information. There's a question in the chat. Are there any issues with taking the second Pfizer dose over 21 days after the first? Someone's child had the vaccine in March, and are there any issues now taking the second dose? So Dr. Kimberlin or Caniza, if you would address that question.
Well, the studies were done with 21-day intervals, and because you need to have, the protocol has to be set a certain way. And of course, the earlier studies with Pfizer in adults was the reason they chose that 21-day interval. Moderna, they chose the 28-day interval, and so forth. So the short answer is it's better to get it at 21-day intervals because you then get your full protection faster, which is 2 weeks after your second dose. But if there is a delay beyond that 21 days, simply get the second dose when you can. And I think the CDC website will say within 6 weeks, but that's simply because they needed an outer number. There's nothing magic about what the outer frame time point would be. It's just simply when you can get it, get it.
Great, thank you. And there's another question that came in during registration that's an interesting question. Dr. Caniza, I'll ask you to field this one. The question is, does the vaccine get killed by the chemotherapy?
I don't think so because yeah, I understand because the chemo, usually the chemotherapy, and Dr. Wong, please correct me. So a lot of these medication, like they use the mechanism is, affecting the mRNA or the DNA, and probably it could be that the question is coming out from that. I suspect that the person, might have that idea. So I don't think so that it's going to affect the messenger RNA because this is a genetic vaccine. Certainly, the RNA is very fragile, and because comparing with the DNA, the RNA can be destroyed somehow, much easier than the DNA. And I think that is why it requires so much care. But I guess that I can pass that that question to Dr. Wang to see what he think about that.
Oh.
But,
I mean, I don't disagree. I mean, the major impact of typical chemo, the things that we think of as chemotherapy, those really impact cells that have at the DNA level, at that very most fundamental instruction set level when those cells are dividing. And that's a time of susceptibility or vulnerability of those cells. So it's very different from the mRNA. And I don't remember if there was, I think it's complicated to kind of think about the differences between, DNA, that sort of instruction manual that is in every cell of your body, and then the mRNA, which are kind of, transcripts that you'll write down from the DNA. The mRNA doesn't typically get affected in the same way because it's not dividing like that. But, I also think that although we've heard get the vaccination when you can, I don't think that we would necessarily give it right at the same time that chemotherapy was in your body. And that chemotherapy would then get flushed out because we only give it cyclically. There may be, I remember seeing in the question list from registration, a question about targeted therapy, which is not quite the same as chemotherapy. It's other medicine. It attacks cancer cells, but it does so in a little bit of a different mechanism than traditional chemotherapy does. That you could rightfully say you might be taking all the time. You might be taking these pills a couple of times or once a day all the time, and that's how your cancer is being killed or being kept in check. However, even in those situations, I would think that the vaccinations mRNA would not be affected by the targeted therapy, which really typically works at the surface of a cell, not at the level of a single page that was copied off of the DNA instruction set, but more at the surface where which is farther down the line. So I don't know the science exactly, but I would anticipate that there wouldn't be an effect.
Wonderful. Well, I wish we could have our discussion go on for another 15 or 20 minutes. It's such a rich discussion, and we have such amazing experts with us, but we've reached the end of our time together. I would like to thank Drs. Caniza, Kimberlin and Wong for their time today, for sharing their expertise with us, and just for your meaningful personal thoughts directed towards our population. Thank you. And I want to thank our attendees for your participation, for your thoughtful questions. We will be sending you a link to the recording of the webinar and send you the slides at the email address you registered with. And I will ask Cynthia to share our PBTF slide deck again. The PBTF has several resources listed here to help you in your brain tumor journey, including our COVID-19 Family Resource Center, our peer-to-peer mentoring program, and our webinar series, which at this link you can find recordings of all of our past webinars. Next slide. And finally, the PBTF is here to help you no matter where you are in your journey. Please reach out to any member of our family support team here at the PBTF if there is anything we can do to help you in your journey. Thank you to our speakers, to everyone, and thank you all for your time today. Have a great day.